So let's get started. You already, I think, heard the introductory slide here. This is a mother-infant dietic program. So what we're going to do today, that's good. Go ahead, next one. Next, please. Yeah, we're going to a little bit, just really quickly over the protocol and the conceptual model, and then some of the efficacy data. And then Dr. Werner is really going to be going into more of the details about PrEP and actually give you a feel for what it's like to be trained in it. Next slide, please. So this was just so recent. I'm sure you're all remembering. It's very brief. It's 5 sessions. You'll hear more about it. We are really view this as helping those who are already at risk for postpartum depression. Next, please. And next, I think you've got the idea that this is really taking a dyadic approach to postpartum depression and really using the research and the conceptual model that mothers and babies affect each other. And this starts in the maternal mind before birth, how she is viewing herself as a parent can be used as part of helping her in the postpartum period. Next slide, please. So, okay, let's start with some efficacy data. So here is a paper that came out, I guess, in 2016. And you can, again, the title, Postpartum Depression Prevention Through the Mother-Infant Dyad. Next, please. So you can see we had a more than half Latinx sample here, typical ages for pregnancy, and they were at risk for postpartum depression based on something called the predictive index of postpartum depression. At baseline, they had mild to moderate depression on the Hamilton rating scale for depression. And for this sample here, we had 100% adherence to the intervention protocol. Next, please. So we were able to cut in half the number of those who went on to have severe postpartum depression. And this is at the 6-week assessment based on the Hamilton. Next slide, please. And then what we're showing you here are the changes in depression scores across the different time points. And if you remember, the intervention actually stops at 6 weeks. So you're seeing particularly, and I'm sorry, I should have defined this, we have what's called enhanced treatment as usual as the comparison group. So these people were given additional referrals for treatment once they were identified as, having these depressive symptoms, meaning an additional meaning beyond what typically happens in an obstetrics and gynecology department. But as we all know, that's not nearly enough. So most of these people did not get engaged in treatment. And you can see really significant differences in the enhanced treatment as usual group really going up in their depressive symptoms at 6 weeks and the PrEP group going down. Next, please. So this was a very similar story for anxiety as well. And then the next slide. And here we're seeing that PrEP was associated with less infant and fuss cry behavior at 6 weeks old, consistent with our predictions. Next slide, please. Okay, so now we're going to do a more recent paper that came out, I guess, just right now. It was funny to look at it. Remember, it was the middle of the pandemic, basically. And this was a sample who were at risk of postpartum depression based on living in poverty and they experiencing poverty. Next slide, please. So this was predominantly Latinx sample, again, very typical ages for having a baby. We defined this, being their context of their lives, being very poorly resourced, based on the definition here of near poor or struggling with this income level you can see of under $50,000. That's for a family of 4. 100% of them were on using Medicaid as their insurance. Now, interestingly, at baseline, they actually had pretty low symptoms of depression. This is on the Edinburgh Postpartum Depression Scale, which is something we could talk about if you have some questions. And here, the adherence to the intervention was 83%, which is still very high, for intervention studies, although it's obviously not as high as the prior study. And we view this in large part as from the social deterrence of health, really making it challenging to continue engaging in the treatment protocol. Next, please. And so here, and what you're seeing is it's a large y-axis, so you get it does amplify the finding that these people were not very depressed or anxious. Anxiety is the far left, D is the middle is anxious, and then EPDS is another depression scale. They were not very high on these mood symptoms to start. And then, however, PrEP did show, particularly at that 6-week period, that people were doing better. They had improved, they'd gone down in these scores. Next slide, please. And we see here that PrEP is associated with more infant daily sleep, again, consistent with our hypotheses, and less crying at 6 weeks old. Next, please. And then also PrEP was associated with higher infant development at 4 months old. This is on the Bailey Adaptation Score. Although importantly, this is a maternal-based rating, which something else we could talk about. We think it's really important how the mother is viewing the child, and that can be reflective of her mood, and also matter in terms of that she's the one who's dealing with the child, so her attributions of the baby, and then how she is interacting with that baby. Next slide, please. Okay, so I've gone very fast through giving you a sense of the efficacy data that we have, and we are continuing to acquire more. And we've also scaled this up in our own obstetrics and gynecology department, really in the obstetrics area, obviously. And Dr. Werner will be talking about not only really giving you more of a feel of PrEP, but then some of the other places that have already implemented this program. So I'll stop there. You want to take it over?
Yeah, absolutely. So happy to be speaking with all of you today. PrEP is our passion, and I'm just thrilled to be able to share it with people from all over the country. I'm going to lay out here the sessions in time so you can get a sense. There's 5 sessions. We start during pregnancy during 28 weeks. We see people again at the end of the 3rd trimester for the 2nd session. The 3rd session we deliver after the woman gives birth. Then the 4th is done 2 to 3 weeks postpartum. And then at 6 weeks postpartum is when we have our final session. So in session 1, we have 3 primary aims. Again, the time frame for this session is 28 to 32 weeks, and the duration of the session is about a typical psychotherapy session length, so 45 to 60 minutes. The first aim is to establish a treatment alliance between the coach, and as Catherine mentioned in the earlier session, we talk about our therapists as coaches as one way to sort of reduce stigma, and then we talk about the people receiving PrEP as participants in PrEP. So they're active participants, and we're teaching them some important skills to help them manage the postpartum period. So regarding research regarding common factors in all types of therapy that contribute to improvement has revealed that the quality of the therapeutic alliance is the most robust predictor of treatment success. So establishing a strong treatment alliance is key and a very key component of this intervention. To this end, we have designed the first session as an opportunity for the coach to begin to develop this alliance with the participant, in addition to teaching them skills and imparting information. So because the alliance has been shown to predict treatment adherence and concordance across a range of diagnoses and treatment settings, we have designed a series of questions that the coach asks the participant. And then based on their answers to those responses, we really tailor all the subsequent sessions to really specifically meet the woman's needs and the circumstances of their life, thereby maintaining and strengthening the treatment alliance over the course of the intervention. And I think that this level of personalization is really key to the adherence numbers that we've seen. Aim 2 is focusing on the mother-infant dyad, and we want to promote mother's maternal reflective functioning capacities, both before the child is born and after the birth of her child. So reflective functioning, as defined by Peter Fonagy and colleagues, refers to an individual's capacity to understand one's own behavior in terms of underlying maternal mental states and intentions. So in the context of parenting, reflective functioning refers to a parent's capacity to keep the child in mind. So that means to imagine and make sense of the child's mental states and to use this understanding in guiding the parent's own responses to the child. And maternal reflective functioning has been shown to be predictive of sensitive caregiving and negatively correlated with hostile, intrusive, or withdrawn caregiving behavior. And then the third aim, so we really get to know participants in the first part of the session. And then at the end of the session, we teach them, we give them something to take with them. So we teach them mindfulness skills, and we also teach them about sleep hygiene principles that they can use both during their pregnancies as well as postpartum to promote affect regulation and better sleep. And one of the things that we give to them is an app. This is a image of the Perinatal Pathways app, and you'll see there's a button here that says meditations. And when a participant clicks on it, they have 3 choices. So we teach them how to do a walking meditation, so something they can do kind of when they're out and about in the world, a mindful moment, which is a meditation we developed that's about 2.5 minutes. So it's a quick meditation that they can do, and also progressive muscle relaxation. We practice progressive muscle relaxation in the session with them because we want them to have the experience of doing it and realizing the benefits as they're happening. And also because it's so great to help people fall back asleep when they wake up during pregnancy from discomfort or having to use the bathroom in the middle of the night. And getting practice during pregnancy allows them to use it postpartum when they wake up in the middle of the night to feed the baby and may have trouble falling back to sleep. Progressive muscle relaxation will have it practiced at that point, and they know they can just pop in their earphones and listen to the meditation as a quick way to fall back asleep and end up getting more sleep than they would otherwise. Session 2. So this is now at the end of the 3rd trimester. It also has 3 aims, and it's about the same length of time as the first session. So again, we're focusing still on reflective functioning and the alliance orientation that we talked about in the first session. We draw on the prior mindfulness training. We ask them how it's been going, what's been working, what's not, and give them some strategies to figure out how they might be able to incorporate it into their lives. And then the third part of this session, and really the part that we spend the most time on, is providing psychoeducation and teaching parenting skills so we can set expectations for the postpartum period and better manage the challenges of caring for a newborn. So first, I'm going to speak a little bit about psychoeducation. And the focus of this part of the session is to provide information about the postpartum factors that can contribute to postpartum depression and ways to address these factors and decrease the likelihood of the development of postpartum depression. So the first thing we talk about is hormones. And I think it's really important to address this hormone drop that happens to all women in the first few days after giving birth before it happens. It's so great to have an expectation of that hormone drop so that people can have some expectation that they may feel a certain way about it. I often talk to people about their menstrual cycles and if they notice any changes in their mood or irritability during their menstrual cycles, and use that as a framework to foreshadow what's going to happen as they enter the very early postpartum period. I think this can be really important in terms of helping people to contextualize, wow, I'm not feeling maybe extra emotional because I'm totally unprepared to be a parent, but instead this is related to my hormones and all these life changes that are happening right now. We explain the difference between the baby blues, which, as I'm sure most of you know, are experienced by most women in the postpartum period, and what postpartum depression is. And so we talk about them being similar to each other, but really postpartum depression symptoms are much more persistent, include sleeping difficulties, changes in appetite, anxiety and panic, really low mood, constant tearfulness. And we talk about postpartum depression as something that can affect their ability to bond with their baby. We also provide them information about sleep. So we've taught them some ways to kind of improve their sleep, but we also give them some information about their baby sleep behavior. So when someone hears that their baby is going to sleep, between 12 and 20 hours a day, that sounds like, well, that's not so bad. I can manage that. But of course, the trouble is they rarely sleep for more than a few hours at a time. So it makes it really hard to get a good night's sleep. We also let people know that sleep is critical to mental health and the physical health of caregivers. We often will talk about strategies to help with sleep if they have a co-parent, how to kind of share responsibilities of waking up at night, because we really want them to understand that sleep and mood are closely intertwined, and lack of sleep can lead to irritability, anxiety, and sadness. It could also trigger or worsen an underlying mood disorder. We talk about crying, and I think what's been so rewarding in both delivering PREPP as a coach and also teaching people about it is people don't know what to expect from their babies in terms of the amount of crying. And so to explain this to them, we give them information from the research of Dr. Ronald Barr, a pediatrician, on the period of purple crying. So we explain that while each infant is unique, at about 2 weeks of age, babies start to cry more each week. And then by 2 months of age, babies are crying more than they're ever going to cry in their lives. And it's really important to know that this is a period of time, so that it will have a beginning and it also will have an end, and babies will not continually cry this way for months and months. And it's important to know also that most babies cry more in the late afternoon and the evening. And I think just giving this framework about the crying behavior is super helpful. We've certainly had participants in PREPP that I would have taken my baby to the emergency room or to the pediatrician 10 times because I would not have expected this to happen without this information. So this has been really great to be able to share this with people. So after we do the psychoeducation, we introduce skills and we say, dealing with changes in your mood and your baby's sleep and crying patterns can be so stressful, but I'm going to teach you some techniques that have been shown by researchers to help improve your baby's and your sleep, lessen the amount of time your baby cries, and improve your mood. So the first thing that we go over is comforting measures. And I often say, you know, a lot of these comforting measures, they're familiar to you. It's so nice to have them written down in one place. And in a bit later, I'm going to show you the pamphlet where we actually write down all of the psychoeducation highlights as well as the skill highlights so that people always have it as a reference for them. But we list all of this so people always have a reference. So you can talk about rocking or sleeping with your baby, taking the baby for a walk in the stroller, you know, running the vacuum, having running water, giving the baby a bath, or using skin to skin contact as ways to comfort their baby. We also teach them how to do swaddling. When we were doing in-person sessions before the pandemic, we would practice it with them. And now we actually have figured out great camera angles to do it over Zoom. So we can actually show people and practice with them, show them before the baby's born and then practice with them live in sessions. Because each PREPP provider has a doll to use. It's, I think, really helpful. And I think people can get overwhelmed by all the fabric and the wrapping. They feel intimidated, not wanting to ask their postpartum nurse after they deliver. And it's so great to be able to give a little extra time and show people this skill, which can be so helpful into helping babies fall asleep and stay asleep. We also talk about the benefits of carrying. And this is carrying, not just using a carrier, but also carrying by hand. Of course, a carrier makes your hands free, which is great. Any new mom knows it's like impossible to like go to the bathroom, drink a glass of water, you constantly have the baby in your hands. So getting used to using a carrier can really be a game changer. We also, there sometimes is concern that if you carry your baby a lot, it's going to lead to spoiling. And we talk a lot about how it's actually it's helpful for the bonding with the baby. It can help you to have a secure attachment, and actually secure attachment fosters independence during the toddler phase. We also talk about how important carrying is in reducing fussiness with the baby. So as part of PREPP, we encourage people to carry their babies an extra 2 to 3 hours a day, independent of when the baby is being fed or being comforted while crying. We also teach people how to accentuate day and night cues. We let them know that most babies are born as night owls, so they might be great at napping during the day, and then they're up and ready to hang out all night. And so we're trying to help flip that schedule so babies are sleeping more at night and awake more during the day. So we talk to people about making the 2 times of day very different. So you could be interacting with your baby during the day. You could open the curtains and not kind of use blackout shades all the time. You can play music or have the TV on in the background. And then at night, you make it very different. We don't play with babies during the feeding time. We make the diaper changes, quite efficient and with as little light as possible. And we try to keep our voices quiet at night. We also teach people some skills to use feedings as an opportunity to help babies sleep better at night. One is the focal feeding. So right before mom is ready to go to bed for the night, this is starting at 2 to 3 weeks postpartum. She can give the baby kind of the biggest feeding of the night, allowing the baby to sleep a little bit longer during that first interval when the mom is sleeping. And then we also talk about lengthening feeding intervals. So once a baby is about 3 weeks old, and it's okay with a pediatrician, just delaying feeding a few moments so that waking is not associated with immediate feeding. And this over time can help babies to stretch those feeding intervals a little bit, kind of building a few minutes each night. And then again, we talk about mindfulness and the ways that you can use mindfulness to manage stress during the postpartum. When babies are fussy or crying inconsolably, it can be extremely overwhelming. And having these mindfulness exercise practiced and ready to use can be really helpful in these moments when moms are feeling overwhelmed taking care of their babies. And I just want to stop for a moment, and if there are any questions in the chat, I'd be happy to answer them.
Yeah, great idea. Only question so far was about obtaining the app, and I think I was able to respond to that and also let people know we're going to have a QR code at the very end for reaching us. Any other questions, either on, I'm going to start calling Liz, either on what Liz has described so far or on anything we've touched on? Great. How do I get trained? Yeah, we're absolutely going to be addressing that. We would love to work with you around a training.
One of my favorite things to do are the training. So yeah, we'd love to do it.
So let's see, here's a comment. And Lauren, if you feel like you're welcome to unmute yourself if you want to raise that comment now.
Sure. Can you hear me?
Yes. Yeah.
So I did some, right now I'm more in like a public health education role for maternal health, but I did my doula training. And so I went and had to observe, some prenatal classes at hospitals and things like that. And it's just funny thinking about how a lot of parents will delay that until pretty close to delivery when they're really feeling already overwhelmed. And then it doesn't include a lot of content like this that you would think would be great if it was more broadly incorporated into prenatal education offering instead of having to be a bit of a specialized thing,
Absolutely. And I think that's one of the reasons that PrEP is designed to be delivered really kind of in any context. It can be done through a mental health service. It can also be done in conjunction with prenatal visits. The timing is designed to work that way. So you could go for your ultrasound appointment and then receive a PrEP session after that. Or you can go for that, final checkup before delivery and then get your the second PrEP session after that.
And will you remind me who is in the coaching roles? Like, does it vary? Does it depend on, I guess, what people have available in their hospital system or their office?
Yeah, so we've trained people with all different backgrounds, psychiatrists, psychologists, social workers, community mental health workers, occupational therapists, nurse practitioners. So we've trained, so it really is dependent on who's available in the system and who's, has access to the type of potential PrEP participants who could really benefit from it.
I just want to chime in too that, in making it more part of routine care, which would really be a great public health approach. And it's when we think about wanting to, sort of redesign care or augment care in the perinatal ecosystem, it would be ideal to be paying more attention to the psychosocial adjustment to becoming a parent. Many people have some kind of stress, and who's going to really tip over to postpartum depression is sometimes hard to tell, but really overall augmenting the kind of emotional resources and tools would be ideal. There was a question here, and I'm not sure, I don't know if it's your last name, but if you want to go ahead and ask us about the 3 questions, which I'm now understanding what you meant, sorry. Do you want to unmute yourself? Are you there?
Hi, I think I asked that question. Yeah, at the beginning you said there were 3 questions that you ask every mother that came in. And
I'm sorry, I didn't realize what you meant by that question.
Oh, not at all. Thank you so much.
Yeah, go ahead. Liz, do you want to go ahead on that?
Oh yeah, it wasn't 3 questions. It's a whole series of questions actually.
Okay.
But basically,
I wondered. I thought, wow, can they ask 3 questions and learn all?
sorry. So yeah, we ask questions about we get a sense of kind of who they're living with, what their life is like right now. Have they had any history of mood disorders? But it's all done very conversationally. And we also ask, so that's sort of one area of questions. And then there's a whole other area of questions around trying to set some intentions around the kind of parent they want to be, having an opportunity to reflect on their own childhoods, their own upbringing, and thinking a bit about, oh, this is something I love that my mother/father caregiver did, and this is something I really didn't like and I don't want to incorporate. So you're helping them sort of build a parental identity. And then the third, I guess there's three areas. So this is a great question because it gets me thinking about our questions in this way. The third area is really about helping it's helping create that dyadic focus for the pregnant person. So they're really we're asking them questions to begin to foster, like, what do you imagine your baby's like? Or what do you imagine will be the happiest times for you when the baby's born? What will be the toughest times? What do you think the baby is going to be like once they're born? And so just getting them to kind of bring the baby into their mind and to begin growing of that relationship before the baby is born.
That is so helpful. And especially for those moms that come in kind of shut down, that are in that high risk, especially if we can get them in there during pregnancy, to be able to like normalize that and have a conversation about that.
Absolutely. And I think
important.
What I've been so surprised by is the degree to which when we start talking about things that happened in their childhood and what they want to incorporate into their own parenting, so many people say, I never thought about that before. And I'm like, isn't it exciting? You can decide what kind of parent you want to be. We can set some intentions together. If they have a co-parent, you can talk about this with the co-parent and kind of create an identity together for what kind of parents you want to be. I think it's very empowering to have that conversation.
Absolutely. Do you ever invite the partner into that conversation?
So the first two sessions, I will sometimes, depending on the context, it's great for them to come to the second half of the second session because we're teaching all the skills, and it's a nice way to kind of normalize it and have both parents working with the same toolbox, right? They both are getting the same, they know the skills, they know the psychoeducation. I think that can be hugely helpful. So yeah, absolutely. And the other time we used to go into the women's rooms after they delivered in the hospital. And that was such a great time if grandma was there, because grandma often, you really got to get buy-in from the new grandma and I think showing them the skills and talking to them about it can be really helpful, especially if they're going to be helping out the PrEP participant with the baby once the baby's born.
Awesome.
I think that the partners is an important direction to think about how we may want to augment PrEP to more specify involving them at some points. I think it's really an important question. So Erin voiced agreement with the idea of some kind of bringing this into PrEP into prenatal classes and birth centers, which I totally agree with. And it's true, as you note, there are not enough birth centers around. Another question from Karen, if you want to go ahead and unmute yourself, or I can ask it. I'm not sure if Karen's still here. The question was, can nurses be trained? And the answer is absolutely yes. We have a mental health team and work really closely with different nurses on the team, and the answer is definitely yes. And great. So I think maybe we'll have you continue this.
Absolutely. Such good questions, though, and I'm really glad to answer them. So this is just a peek at what the informational pamphlet is. So in the first session, we give the PrEP participant an app to take with them. And in this session, we give them an informational pamphlet, both in PDF form, as well as we send them a paper copy if they want it. Some people just like to have it on their phone so they can easily scroll through it, and other people like to have the physical copies. So we have both available. So this is what the pamphlet looks like. We're really in this first page trying to normalize, that it's really challenging to be a mom to a newborn baby. And every mom, every parent can have times when they're feeling really stressed. And this is even more true if you felt overwhelmed during your pregnancy. And then we list here the challenges of being a mom to a newborn. And this is, again, a way to sort of normalize how difficult and challenging this period can be. And I think if people expect that everyone else is having just a grand time in the postpartum period, and they're the only ones who are really struggling in this way, or they're really, an aberration from what the normal experience is, I think it can be really, really contribute to negative self-attribution and can make women feel disconnected from other mothers. It can make them feel more depressed. And so being able to spell out a variety of different challenges that many women experience, I think can be really helpful. Again, we give them information about the postpartum hormones just so they have it right there and they know what to expect. We talk to them about purple crying, and we have it here as well as a link to the purple crying website. We have the list of the skills here, the comforting measures. As I said, we give them a list. It's things that, seem like common sense and stuff you sort of know, but it's so great to have it written down. We also provide them with a diagram here on how to swaddle. We talk to them about the benefits of carrying and how to safely carry your baby. We talk about how to accentuate day and night cues for better sleep at night. And we talk about the techniques I just explained to you about how to help babies to sleep longer by using feeding techniques. We explain mindfulness again on the pamphlet, and we also give them a hospital packing list. And that just makes it more likely for them to bring it with them and to keep it in the front of their mind. And then it's session 3, and it's time for them to deliver. And so we try to be in contact with them within the first few days of giving birth. And the session we found is best when it's brief, because there's a lot going on in those first few days postpartum, but it's such a great time to check in. So the first is to check in and see how labor and delivery went. I think this is so important. Women often can feel forgotten, like everything's about the baby, and people have forgotten to ask them how they're doing. So we always ask about how their labor went. And I think this is a nice way also to kind of keep the alliance strong. We review the materials we discussed in sessions 1 and 2, and we talk about the timing of when you can start using them. So some of them they can start using right away, like swaddling, for example, and some of them we're just sort of foreshadowing. So in a couple of weeks, you can use the feeding techniques that we talked about. And this is just kind of helping them build a time frame. We also remind them, remember, around 2 weeks, you may start to see your baby crying a little bit more. So important to have an expectation about that, because many women, they bring their baby home, the baby is crying, but not that much. And then they've had the baby home for 2 weeks and they start crying more and more and more. And oftentimes, if you tend towards negative self-attribution, you think, I'm a bad mom. I had this baby was born, they were doing great, and they've been with me for 2 weeks and now they're crying all the time. On the other hand, someone who tends towards negative attribution towards the baby can think, I have a bad baby. And that can really be disruptive in terms of the dyad and having, a positive feedback loop between mom and baby. And then we have session 4. And this one takes place between 2 to 3 weeks postpartum. And again, it's another brief session, about 15 to 30 minutes. It could be done on the phone. It can be done over Zoom. And so the first part of this session is, so the dust is sort of settled at this point a little bit. They've been doing this for a couple of weeks, and they're kind of getting a hang of certain things. They may have started using some of the PREPP techniques. They may have been feeling pretty overwhelmed and not quite sure where to start. So this is a great time to talk, because there's lots of things that they can start doing at this phase. We can check in about how swaddling is going. If it's not going great, we can be on Zoom and we can demonstrate it and they can do it along with us, which is really helpful. We can talk about if the baby's been gaining adequate weight, how to start using some of those feeding techniques to help the baby to sleep longer. We can talk about carrying, how often they're carrying the baby. By this point, many babies are, weighing enough to use most of the major brand carriers. Some of them can be used with even very small babies, but some of them, like the Ergo 360 or some baby Bjorns, can't be used until the baby's 8 pounds. So oftentimes this is a time when the baby's getting close to that weight. And so we can talk about how to use them and how that can be helpful for them. And we can talk about the mindfulness techniques. And I think it's really important to remind people, you've not been sleeping very much in the past 2 weeks. How do we check in? How do we use progressive muscle relaxation to fall back asleep when you get up in the middle of the night to feed the baby? Are there any of the sleep hygiene techniques that we talked about in session 1 that we can start reintroducing into your life now? This is now, you're kind of dealing with a crisis, an emergent situation when you first have the baby, but how do we settle into routines and techniques that you feel good about, help you feel efficacious as a parent, and help you to feel good in terms of getting a little more rest than you've been getting in those past couple of weeks? And so sometimes, of course, people are not so sure about things, or, they're feeling so overwhelmed. And this is the time when we teach the PrEP coaches how to use motivational interviewing techniques to sort of build that confidence and that engagement so that they start using those PrEP skills. I think it's really helpful to do this. I think it's hard. We've got so much going on, but these are skills that they can see the effect of right away. And the better they get at them, and the more you talk about them and make them feel comfortable with them, the more they feel confident in using those tools in the toolbox. It's important to say, though, we never sort of treat the introduction of these skills or this information as something they have to do. We are providing you with tools, and you are the parent, you are the expert on your baby, and we really want them to feel like experts on taking care of their baby. And so those tools you use at your discretion because you know what's best in your situation. And I think that approach is really important because you're really working together in a partnership, as opposed to I'm the expert and you don't know anything and you should do what I'm saying. You really want to be listening also to what they're telling you about the baby and be a fellow problem solver and helping them manage all these challenges of the postpartum period. And then we're at the last session, which is 6 weeks postpartum. This is a full length kind of psychotherapy session, 45 to 60 minutes. And there are 3 aims to this session. We're checking in on mood, really asking them how they're doing and how they've been feeling in the postpartum period. Number 2 is we want to kind of assess their utilization of the PrEP tools, what's going well, what's not going well. For some babies at this point, swaddling is, a joke because they're like little Houdinis and they figure out how to get themselves out of their swaddles. And so there's no point in, for some babies, swaddling is great for the first 3 weeks and then just not helpful anymore. And so we're not about trying to change what works for the mom and the baby. But maybe at this point, the carrier would be a great thing to start talking about. And how can you simplify their lives just by getting them comfortable with using the carrier? And then we talk about, we've assessed their mood and we've assessed kind of what skills they're using. And this can be an opportunity to problem solve what areas they need some extra help with. We might want to talk about, so you've been doing every single night feeding and you've, without fail, and you haven't slept at, more than 2 hours at a time in 6 weeks. Is there, do you have a co-parent that you live with? Does your aunt live with you? Does your mom live with you? Is there a way that they could be helpful to you in this process? And just problem solving kind of within the specific circumstances of their life to help them get a little bit more sleep, or helping them to think about ways they can emphasize day and night cues if their baby is really still sleeping all day and not really sleeping very much at night. So that's the 3rd aim of our final session. It's always really exciting to see people at this time. We've been pretty fortunate that when people get to this stage, they're feeling good. They've got opinions about what the best things are for them and their baby. They're using the skills. And oftentimes their mood is good. And a lot of times also the babies are starting to cry more at this phase, but there's this sort of understanding that this is a normal developmental phase and it's not going to go on forever. And I think that's hugely helpful because so many times people think it's a GI issue and they're at the doctor's office all the time. And just having some information about what to expect really changes it from something that's pathologized to just, this is kind of a tough experience that we're going to get through and it's not going to go on forever. So someone asked that they were interested in getting trained in PrEP. We would love to train you in PrEP. I really, really love doing these trainings. And you can see here, and I think things are going to be sent out to participants, I believe. Right. So this is the website, and this is exactly where on the website you can sign up for PrEP training. And the trainings are designed to be straightforward, tailored to the intended clinical population. So what I like to do in the beginning of any training session is find out who are you working with, what's the context in which you're working with these people, and then as we're doing the training, really tailor it to that specific clinical population. I like to customize the training to a trainee's experience and any previous training they've had. The great thing about training now is we don't need to be in person, although that was fun, but we can be totally virtual. It's really nice. We've trained people all over the world, and it's so amazing that we get to do it so easily now through Zoom. And the training requires about 8 hours. And we've had people who do it like 4 2-hour trainings. We've had like 2 4-hour trainings, and then there's a 1-hour certification assessment. And again, we talked a little bit about this last time, but these are all the different clinical backgrounds of people that we've trained so far. But I think anyone working in perinatal health, perinatal mental health would be someone who would be a great candidate for learning this intervention. So we've trained clinical psychologists, psychiatrists, occupational therapists, social workers, case managers, community health workers, nurse practitioners, NP students, social work students, and master's level psychologists. And these are some of the institutions where people have been trained from. And I just want to say thank you for all the people who funded the research and the work that we've done in PREPP. It's really been great. And I'm really looking forward to any other questions that people may have.
Right, we do have some other questions and comments, and I'm actually just going to jump in for a minute because we got to the 6-week session, and I want to call back. I mean, actually, maybe Liz, you can go back to our data slides, particularly from the first study, just to highlight something. If you remember that we really saw big effects in the 6-week period, and I wanted to use this opportunity to highlight why we think that's so important, and particularly in terms of prevention of postpartum depression. That this is the time when women often get diagnosed with postpartum depression or postpartum anxiety, and if we can keep them away from that diagnosis and get them feeling better at this time, as you've already gathered, we really view this as a time of getting mother and baby off onto a better start and a positive feedback loop. But it also keeps them away from potentially, a diagnosis that didn't have to be, that they could do well with PrEP. And that's really important in terms of our limited mental health resources. And it's also important in terms, it can be, at least initially, while we need diagnosing for, obviously, for insurance reimbursement and often to get people the care they need, it can often come with a sense of defeat, and there can be a brief period where it's that the recovery is slow, if you will. So it seems that PrEP is really showing that there's this group of women who are, and we've shown you 2 different samples, 2 different demographic samples at risk for different reasons, who do really well with PrEP and are doing particularly well at that 6-week postpartum period. So in a sense, avoiding what might have been a diagnosis of postpartum depression and going off on that trail. Certainly some of them really may have been really not doing well, and they need that, but there seems to be a good portion of them who do really well with PrEP, and that's sufficient. In fact, if you go to the prior slide, where you can see that the percent of women who, this 43% is what you would expect of women at risk for postpartum depression, not getting any treatment, to end up with with a severe postpartum depression postpartum. So again, women in pregnancy who have a lot of risk factors, that 43% is what you would see as, if you will, converting to postpartum depression. So that we cut that in half really is meaningful to us. And as someone wrote in the chat, this is, fairly easy hanging fruit in terms of a kind of intervention to really help pregnant people and their future children. So I wanted to
just add one, if it's possible, just
Please.
Related to this. I think what's so amazing is that for the people who, many of the women who we see through PrEP end up doing really well. The people that aren't doing really well, there's someone who has eyes on them. If they're starting to not do well by 6 weeks, and they're starting to look not, we can refer them immediately into other treatment in the community. And oftentimes, when I will get a referral through our clinical service for someone with postpartum depression, they've been suffering for months. There's been effects on the family for months, and it's so wonderful to be able to intervene as it's happening and, potentially refer them to more intensive treatment.
Yeah, great. So glad you brought that up. So Lauren Murphy, you have a comment question if you want to raise it, or I'm happy to ask it.
Hi, can you hear me?
Yes, absolutely.
Oh, hi, how are you? I was just wondering about patient engagement. We're having a hard time, even for any of our prenatal services right now, we're having a hard time getting the doctors on board and, even the patients on board. Like maybe they'll come to a session or two of any sort of prenatal education, and then they're not really engaged. If it's virtual, they don't turn their cameras on or they don't return. And I just wanted to know if you had any advice on that, or what you guys are doing.
Yeah, I know Liz is going to have a lot to say, but I'm just going to jump in with one idea. I think that the fact that PrEP is focused on the future child and the child that they're carrying can often work really well to engage people, that it has that piece to it. Now you're saying you're already trying the baby education, but if you're framing it as, if you were doing PrEP as something that is going to help you and really give you tools for parenting in a way that can really make this challenging period more manageable for you. Do you think that kind of framing would help? Because that's one thing we think about PrEP, is that since it's focused on the diet and the mother and in the caregiving role, that can help engage people.
Yeah, no, I do. I just feel like, and maybe it's like a broader question, just with like post or during COVID, it feels kind of like people are getting education and resources like elsewhere. I mean, I know that's a larger, more broader conversation. Just even with like our prenatal education classes, the numbers are down. So that's why, I would love to implement something like this. And that's why I'm just trying to think of ways to engage people more.
Yeah, I always say about PrEP, I'm like, oh, we have this program and it helps babies to sleep more and cry less. And like using that as a headline, people like talking about education, about caregiving or those kind. I mean, you can really lose your audience, but if you tell them you're going to help them so that their baby sleeps more and cry less, that's been very motivating for people, I think, who are less likely to be motivated to do something like this.
And then just to add, that's so important. And then we often in PrEP though we want to again manage expectations that these are really great tools. Not any tool works all the time. So you also have to manage sort of the expectations. Yes. It's not going to be a magic bullet. And
that's the kind of foot in the door.
Right, exactly. Foot in the door.
Foot in the door. And then you build the alliance. And now they have this trusted person who didn't just spend 5 minutes with them, right? Like someone who they've talked to and knows some things about them and is presenting skills, thinking about who they are and what their life circumstances are. I think all those things together have helped us kind of hook people in and make them feel committed to doing it.
Thank you.
Yeah, thank you for the question. And then Lauren K., you asked about getting referral. And I think that Liz addressed that. Does that help you? Because we are really we do view PrEP as very advantageous for we're engaged with people, they're engaged with us, but it's also an opportunity to be checking in with how people are doing in a more rapid way, as Liz described, to get them added resources and mental health care if they need it.
Yes, I feel totally answered. Thank you.
Home visiting, and Nina, and I hope I pronounced, do you want to ask that question? Are you here still? The question was, how does this program work with home visiting programs? And that's, we haven't yet adapted it to home visiting. I think we'd be really interested in doing that, and it could work super well. So it's
absolutely the first and second session. Yeah. And it can be delivered, this has been something we start during pregnancy. However, in our clinical service, if there's a case that someone does a referral right after someone gives birth, we have started people postpartum and been able to adapt it that way. So there are a lot of different ways that PrEP could be adapted to different kinds of contexts and situations.
And then Williams F., do you want to ask your question about social determinants of health?
Yes, thank you. Yeah, just basically what I wrote. This is great. I just wanted to know whether during your initial encounter with the woman and birthing person, whether you screen for social determinants of health, because we're all aware that, if that's at the forefront of your issue, it's going to exacerbate whatever other issues you have going on. And if you do and determine it positive, do you provide them with resources on how to address those first as you deal with whether there's any issues with depression or anxiety or anything else? Thank you.
Yeah, go ahead. You want to answer?
No, go ahead.
yes, we ask a lot of kind of open-ended questions to get a sense of what's going on with people and what they identify as sources of stress for them. And if there are issues, and so in terms of if there are issues, we're often finding ways to be connected with social workers in a clinic that maybe referred them, and figuring out how to connect them to getting care in those ways. In the second clinical trial that Catherine talked about, there were a lot of people really struggling with issues related to poverty. And I would sometimes be thinking to myself, like, gosh, like it feels so hard. There's so much going on here, potential homelessness, like huge, huge challenges. Can PREPP really help? And it was amazing to see that it did. It built confidence, it gave skills, and it was, you know, something very helpful, in addition to, of course, like social services and other types of agencies that can get involved and provide some support. But I was always amazed by people talking about this. And I think in some of the patient descriptions that you gave, Catherine, it really can make a difference.
No, I realized, Liz, you could probably stop sharing the slides. We've got more questions, but then we can, you know, anyone who wants to turn their camera on as we're talking.
You want me to go to the last page just so we can have people?
That's right. If people want to, be sure to do the QR code. Karen also asked about assistance with funding for trainings. And, you know, what I would say is at this point that I think the trainings are very modestly priced, and we're working on getting CME credit. And if the cost is a barrier to training, just let us know, and we'll try to work with you, because it is, I think, a very, very modest cost. Lauren, do you want to share your comment about the 6 weeks postpartum?
Oh, yes. I'm in Georgia, and I had been working with people that were trying to, you know, reformat, update postpartum care bundles and warmer handoffs with community agencies and such. But one of the big things that always came up was speaking about postpartum follow-up visits, and how a lot of people don't get them till 6 weeks. Some people never show. And it's a shame, because sometimes if you know anything about seeing pregnant people, if they're not in a program like PREPP or something, right, and someone doesn't have eyes on them, it can be a very important thing to see them prior to 6 weeks. So it was just nice to hear that you guys make sure to check in.
Yeah, I think those check-ins, both right around birth, which is, as Liz described, which is, we really try to be super respectful in the way that we designed it, that it's not a full session, it's the time that they can do. For some, it's a very brief check-in, for others, it's a bit longer. But then that 2-week time point is super important. This, as you can tell, is also an intervention that is oriented to relationship. It's brief, but I'm sure you gather, as Liz described it, there's really an investment in the unique person, what's going on in their life, and that alliance getting formed. Let's see, there was another question about access to the slides. And I think that the slides from the first part are going to be shared. And I guess we have to figure out about sharing the slides, because so much is here is the training. And it's not the proprietary aspect as much as we'd like to train people and have them engage with us rather than just take material and do it. As you can tell, Liz is super skilled at training, so we really like that engagement to pass it on. So please contact us, you know, about training, and then as part of the training, you can get the pamphlet and these kinds of slides. And the cost of the training, I want to say that do you know what we finally landed on, Liz, or it's a range?
Yeah, it's a range depending on how many people are getting trained together, but we're happy to share information if you email and you give us a sense of what you need. Happy to share that.
And there's a last comment, and we're running out of time, but just we really appreciate that you're hearing that in PREPP, this helping the pregnant person to consider their role as a mom and how they see themselves in light of their new role in efficacy. That really is part of what we are thinking about, that transition to parenthood. And that can be happening if it's your third child. So thank you so much for engaging with us. I think you know how to reach us, and it's just wonderful to have this community of people who are not only caring about maternal mental health in children, but caring about starting earlier for prevention, postpartum depression and other real challenges.